For today's presentation, the title is basically, do we really know how well we perform? And I think as surgeons, we're often guilty of believing that we do a better job than we actually do. And it's important to reflect sometimes on what is the real data. So I'll share with you some of the work we've done looking at GU oncology care within Ontario and across Canada. And one of the terms you'll read about is quality. And everyone uses this in a very haphazard way. And it's one of those words where you kind of know what quality is, but it's not easy to define. How do you measure quality? What's an appropriate benchmark? What do we set as a standard, as an acceptable level of quality? Who should be aware of the results? When you look at outcomes for an operation, whether it's an adverse outcome, complication rates, or a successful outcome, should that be posted on a website for all patients and consumers to see what institution or local health regional networks have as a performance measure? And lastly, what I think is most important, and I don't know how well we do it in surgery, is how do we improve? Before 2005, that's the year I came back to Toronto, I would say that there really wasn't a great deal of measurement going on in uro-oncology clinical care across Canada, at least from a large administrative database type approach on a population level. We had insight into some outcomes through QOG type trials. For example, the use of androgen deprivation therapy neoadjuvantly and looking at prostatectomy outcomes in that setting. And we had publications from centers of excellence. So what I embarked on, and when you look in the epidemiologic space, there's many subdisciplines you can choose from for a career path. And what I pursued was what's called health services research and then knowledge transfer. So the health services is the afferent arm, if you wish, where you actually figure out what's going on, and the efferent arm is knowledge transfer. So finding out what's happening is actually beneficial, but more importantly, it's what do we do to improve it, and those are the knowledge transfer initiatives. There's challenges with health administrative data set. Many people are sick of seeing studies being published with SEER and constantly big numbers and publishing data, but it's important because it really tells you what's going on. I think in a big picture across jurisdictions. Confidentiality, retrospective concerns, coding accuracy, and then the intangibles. You don't know what patient preference is, so you may look at what a patient received as a form of therapy, but you never have insight into the encounter, and maybe it was the patient's wish to have one procedure versus another, and not necessarily the clinician's incompetence for not offering option B. So why don't we start off, and we'll look into bladder. And for the bladder work, I'd like to give credit to Girish Kulkarni, who was a resident, did a PhD in epidemiology at our center, went down to Memorial, and now he's back on staff with us. And Girish was able to put together a very large and rich database at the province level. And I won't show all the data because we also have some wait times data. I'll just show his volume outcome studies with institution and provider as the variables. And we know that cystectomy is probably the most consistent volume outcome operation we perform as oncologists. Actually, a recent publication in the New England Journal of Medicine demonstrated again that along with the Whipple, esophagectomy, and AAA, basically radical cystoprostatectomy or cystectomy, pelvic lymphadenectomy, demonstrates a volume outcome relationship where high provider, high institution volumes are associated with a better outcome. So when you look at Ontario and we break out the quartiles, the higher quartile hospital volume and the higher quartile surgeon volume were associated with lower operative mortality, and this was statistically significant. These are the time to event analyses, or Kaplan-Meier curves, and again you can see that the quartile 4 has a more favorable curve, and this is very consistent with what's in the literature from the United States. Some other disturbing trends that came to light when we looked through the data set were that 1/3 of the radical cystectomies had a lymphadenectomy, so basically NX. And of those that had a lymphadenectomy, the median or mean number of nodes was 6. And I think most of us are aiming for 12 or more with our template today. So what do you do with this information? And so you disperse it, you present it. One of the things we sought to do, I work with Anna Gagliardi. She's a knowledge transfer scientist, and this is work in progress, but we received a grant from the Continuing Education Office at the U of T, and we developed a self-audit kit. So basically we put together a little kit that gives the provider background data on what they should be doing, and then how to go about auditing your own practice. We gave them a strategy to pull their cases, what to look for, and then we phoned them and we asked them what they thought about the kit, and did they like it? Would they do this again? And actually 20 people signed up, and it was very favorable. Most surgeons are interested in their results. It's just they get very busy in their day-to-day, and it's only when you offer them the ability to go and look at their charts and you try to help them go through it, and you do it in a very non-confrontational manner, and you're not going to publish their results, but you're really looking at the exercise and not how well they did, that they were on board. And most of them felt that they learned from it and that they would change some of the things they did. We then moved on to upper tract, and I think this is probably one of the more challenging diseases uro-oncologists face. It's also challenging because each of us sees a handful a year, and it's managed, I think, by all urologists and not just a few who have an interest in this one disease. And what we looked at, and this was when Rob Abowassaly, our fellow, was with us, and now he's at Case Western. He also did a master's under us in epidemiology. We looked at the Ontario data. So we put in an application, and we identified about 700 cases over 10 years of nephroureterectomy. And the numbers were pretty consistent, again, with published literature demonstrating that the disease distribution is very similar to America. And the 30-day mortality was 1.7%, 5-year survival 50%. We know this is a tough disease. And we looked at some variables that we thought would be interesting. And before going forward, we looked at 8 consecutive nephroureterectomies in-house just to see what you would expect for ureteral length. And the mean was 20 centimeters. And our standard is a laparoscopic upper with a lower formal cystotomy excision of the ureteral orifice. And what prompted our concern was, although it may be a bias, is we tend to get the stump recurrences at our center. So we see them, and you always wonder, what's that as a number? Does it exist? Why are we seeing them? Are we biased? What's the denominator? Are there that many? So when we looked at ureteral length, 26% of the cases had a ureteral specimen length less than 10 centimeters, and 10% had ureteral length less than 5.5 centimeters. So clearly, many nephroureterectomies in the province of Ontario are not having a complete operation. Now, one may argue, what is the consequence of that? Is a stump recurrence lethal? What were the intraoperative factors that may have driven it? So this is the void with health services research. I can't answer all of those questions. I can only tell you what we found. 20% had lymph nodes identified with a median of 1. When we looked at logistic regression to see what predicted for complete ureteral excision, stage was associated with it, and academic institution approached significance but didn't. And bottom line is, if you were treated in an academic center, you were twice as likely to have a complete ureteral excision. And so you have to be careful when you put this out there, because you're not telling your colleagues in the community that we're better than you, but on the one hand, you want to look for variables that may predict for it, and you want to turn it around and encourage them to do the same. So that's the upper tract piece. We then moved into kidney cancer, and we know that I think kidneys become pretty hot. Small renal masses, everyone's seeing more of them, filling up your office, and how do you manage them? And again, I always wonder, as surgeons, are we really moving with the data and moving with the time? Many more small renal masses, and I would say a greater push towards partial nephrectomy, even though we now have a wrench in the plan with Van Poppel's randomized control trial demonstrating equivalence between radical and partial. Separate from that, though, patients with diabetes, hypertension, and risks of chronic kidney disease may or may not be receiving partial nephrectomy. So these were many of the questions we had when we applied to CCSRI, and we were lucky to get funding to look at Ontario and Canadian level data in terms of surgical management of kidney cancer. And when we look at the American experience over 6 to 7 years, their partial nephrectomy rate rose up to about 40%. We still don't know what the appropriate number is, but at least it was going up, so the message was penetrating. In Ontario, we started with the Ontario Cancer Registry, and again, we looked at the 95 to 04 window, and I'll give you some updated data later. We also had some other thoughts. We were curious to see, how did laparoscopic radical nephrectomy roll out in Ontario? Who took up the procedure? What was the morbidity? What were they operating on? And so 7,800 cases, of which roughly 10% were partials. And our first hypothesis was that the introduction of laparoscopic radical nephrectomy impeded the uptake of partial nephrectomy, and actually that's what this slide shows. And this was statistically significant. If you look at the green line, this is partial nephrectomy going up. The slope of it is upwards, and then it starts sloping down. And laparoscopic radical nephrectomy slopes up steeply, and total number of cases going up. So very important data for a few reasons. One, I think for stakeholders, for providers of resource, that we're going to be seeing more kidney cancer, and more kidney cancer surgery is going to happen. So the government, someone needs to be aware of this, because it's going to grow in, the space is going to grow. The other message is that we basically embrace the technology here, and we may have lost sight of what the clinical management should have been for this patient. Interestingly, in Ontario, until recently, laparoscopic radical nephrectomy remunerated at the highest rate, followed by open radical, followed by open partial. So you would get paid 1.5 times the amount of an open partial if you performed a laparoscopic radical nephrectomy. So I'm not suggesting that that was the incentive, but stepping away and looking at carrot and stick, perhaps changes in the fee schedule may incentivize or disincentivize behaviors in the management of this.
How much of a factor do you think that active surveillance had on the drop in partial nephrectomies?
Good question. People ask that at this point. Essentially zero, because that was 2002, and there wasn't even a publication on observation of small renal masses before 2002. Again, in Ontario, it was non-existent. So really, London, Toronto. Toronto was one of the first John Couture Mount Sinai Hospital. London, I know in Calgary there was some crowd, but this is Ontario data. So we were familiar with what, and I don't want to show you all the data, I don't want to bore you, but we also have procedural codes, CPP, CPI codes that tell us what procedures were taking place, linked to the ICD code, which gives you the diagnosis. Yeah. And I'll show you now the data, it's going back up again. So the intent we will not know, but the association is real. Who does partial nephrectomies? Again, it's interesting. About 5 surgeons actually performed more than 30 partial nephrectomies in that time frame. The vast majority were low volume, 1 to 2 or 3 partial nephrectomies. Everybody doing a little bit of everything. And again, very important to see what happens in your backyard. More for the residents. When you read the literature, there's a strong publication bias. Centers of excellence or high volume centers publish their results. What most people think is a positive surgical margin rate in partial nephrectomy, when you'd ask them, they'd say about 3%. And many people will actually quote that without knowing what their true positive margin rate is. So in Ontario, the positive margin rate was 11%. It was about 4 times the published rate. And I think we got some half-decent surgeons in Ontario. But again, very important. So now the question is, do we encourage more partial nephrectomy, or do we step back and have a forum or an opportunity to discuss, which patients should have a partial, how do you do your partial nephrectomy, or maybe each center should select one surgeon to do them. So has anything changed? This graph doesn't project well, my apologies. So what we did is we got a fresh cut of the data in 2007. Ignore the last part of the graph, because that's an incomplete year, and that's why all of those lines are dropping down. So just look to this level here and back. So the partial nephrectomy is the blue line, and that blip downwards was what I demonstrated, but now there's a rise. And what you can see is that partial nephrectomy is rising. Okay, laparoscopic partial nephrectomy, which was introduced, is a tough operation, and you can see the uptake on that curve is flatter. So that will require many more surgeons going and getting fellowship trained in this, and many residents eventually learning this to see that curve pick up. Interestingly, laparoscopic radical nephrectomy surpassed open radical nephrectomy in the province of Ontario. So we are now performing more lap radicals than open radicals. Again, important, I think, from a cost perspective and for planning going forward. Overall, kidney surgery going up, up, and up. And that now is relevant. Andrew, your comment about active surveillance, that's in the background of seeing some active surveillance for small renal masses and ablation. So if you superimpose those, you would see even more cost for the management of small renal masses, because you have to add those two. One of the other things we looked at was adrenal sparing nephrectomy, right? 5, 10 years or more now, we've had multiple papers stating that ipsilateral adrenalectomy is unnecessary unless the CT or MR demonstrates adrenal involvement, and some would even argue if there's a large upper pole tumor, even then it may be unnecessary. And you may wonder what's the big deal with this, but I'll talk about that in a second. So we looked in Ontario, and this is Stan Yap's work. He's Chris Evans' program. He's our fellow now. And over time, regardless of the tumor size, adrenalectomy was still happening at a very similar rate. That's broken down by 4 centimeters or less, and you would think, why would a tumor 4 centimeters or less have an adrenalectomy with their nephrectomy? And 4 to 7 and 7 or more. So interestingly here on multivariate analysis, I'll just cut to the chase in the next slide. What's associated with adrenalectomy is male gender of patient, academic center this time. So, you know, we walk around and think we always do the right thing and we lead the way. Actually, with this one question on multivariate, an academic center was associated with more ipsilateral adrenal. When you do a multivariate, that controls for disease. So each variable is independent. High volume centers, procedure year, left-sided surgery. That's an anatomical thing. I think it's within reach, more easily removed. Laparoscopic did not play out statistically, and I thought that that might. Tumor location size, venous thrombus. So from a knowledge transfer perspective here, we're still taking out about 40% of the adrenals that we probably shouldn't. We just had an abstract accepted at the AUA when we looked at survival. So we only took tumors that were 4 centimeters or less. We took out all adverse features, and adrenalectomy, don't ask me how, whether it's some physiologic phenomenon, is associated with a worse survival outcome than preservation of an adrenal. And that is overall survival, and cancer-specific survival was equivalent. So it may not make sense, who knows, but it was thought-provoking, and someone needs to look at that. We always think we have another adrenal that works, but separate from that, if you take out the adrenal gland and contralaterally they develop an adenoma or a met, you got a clinical dilemma on your hands because now you may render someone adrenal-less. 30-day mortality, important information again. I think this plays into the active surveillance piece. I showed this data last night. We often consider surgery in older individuals and we think that it's not a problem, but what you realize is that it's about 2 times the odds of dying within 30 days for every increase in decade of life. Octogenarians in Ontario that undergo any form of kidney surgery have a 6% 30-day mortality. That's a real number. It's 1 in 15 basically. So if you're looking at a small renal mass, perhaps not a bad idea to consider a different strategy, especially if they carry significant comorbidities as well. So we went on to look at the Canadian level, and we were funded here again by the Canadian Cancer Society. And Rob was our fellow, and I collaborated with Shabir and George. And this is a CAIHI data set, so this is very different. So now we went across Canada, and we were able to get every hospital admission for a kidney cancer operation and whatever happened within that admission. Ontario, BC, Atlantic provinces, and basically we had most jurisdictions covered. Quebec is excluded, and some of non-Winnipeg, Manitoba. And these are the numbers, so looking at happening in Canada. Basically over a 10-year period, we've grew the kidney surgery numbers by 50%. So we performed 2,000 procedures in '98, and in 2007, 3,000. So we're seeing this on the rise. And partial nephrectomy was 17%. When you look at the provinces, I think it represents populations. Ontario is usually about a third, so about 12,000 of the procedures being performed there. And physician volume, again, a handful of very high volume surgeons in the country, about 43. Number of procedures over time, rising. Partial nephrectomy use over time, rising, not bad, 26%. Use by age, a bias. Younger patients get partials, olders do not. And older patients may benefit. We don't know the right answer there. Income quintile, wealthier patients are more likely to have a partial. Perhaps they read, perhaps they see physicians in a different jurisdiction. The numbers are the numbers.
Can I ask a question? Yeah. So that's 16.2 versus 19.
Correct. So you have to be careful with very large numbers. Statistical significance will be achieved. So what you're referring to is relevance. And is a 3% difference relevant? Correct. Is it meaningful? Right. I don't know. When I usually show this data, I throw it out there and I try not to be judgmental on this data set because of the numbers are huge. Go ahead.
So from your perspective, is that statistical significance a socially and clinically meaningful difference?
3% doesn't sound like a large number. The flip of that, though, is it's about a third more likely, right? So if you divide 16 by 3, it's about another 5 points. So you can do relatives or absolutes. So on an absolute difference, it's not impressive. On a relative difference, I think it is. Is it something that should be written about and published? Unlikely, if that's what you're asking me. I think maybe a 10% difference would be real. Because what's the real number here? The denominator was about 800. What was our denominator? We performed, we know the denominator, here we are, 5,000. The denominator's on the bottom. So 5,000, roughly equal number of cases in the very low. So it's basically 3-4% of 5,000. 150 cases, right? It's about 150 cases difference. Yeah. So it's not huge, but it is. It's about 150 cases. Charleston category, okay, and regional. So when you look across, again, and I don't mean this in any disparaging way, but there's slight differences. So the range is anywhere from about 14% to 19% in terms of the proportion of cases that had a partial versus a radical. One of the slides I didn't include was a correlation coefficient with disparity in radical versus partial nephrectomy remuneration. And the jurisdictions where the difference was greatest, where the dollar amount was greatest in terms of how much you got paid, actually was a straight line from bottom left to top right with more or less partial nephrectomy. Volume, higher volume centers, higher volume physicians, more likely to perform partials. That could be a referral. That doesn't necessarily reflect that a higher volume individual thinks of partial more. You may be funneling your cases to the high volume surgeon who does partials. And one of the questions we had was diabetes and hypertension. And again, what we showed here was that unfortunately it didn't make a difference in Canada. That if you had hypertension, which is the number 1 or 2 leading cause of chronic kidney disease, or if you had diabetes, you were still as likely to have a radical nephrectomy as if you didn't have one or both of those conditions. So although we might argue that an elective partial nephrectomy for a tumor less than 4 centimeters is debatable, I think most of us would say that if a patient had diabetes for sure, hypertension or both, that a partial nephrectomy should be considered in that setting. And it didn't make a difference. So how about age on morbidity? So we looked at age, and the overall complication rates 35%, in hospital mortality slightly higher with radical than partial. And I'm pleased to report that actually over time in Canada the complication rates have come down. So surgeons are doing a better job, institutions are providing greater services, and I think in general patients are being better served. If you look at age, older patients were more vulnerable. Again, a message for the small renal mass entity and the management of these patients. And again, although we had many statistically significant variables, again, there's a very large data set, so it's easy to get that. But when you looked at the multivariate logistic analysis for predictors of complications, age, Charleston, and surgeon volume as well as hospital volume were positive, and hospital volume was strongly positive for both partial and radical in terms of complications. In hospital mortality, very high again, 5%. Whether it was a partial or a radical, if you were over age 80, 5% never left the hospital. The multivariate logistic regression analysis for predictors of death, age, institution volume, weekly, positive but positive, and comorbidity. And I think age and comorbidity here are clearly the messages, not the other. So in summary, partial nephrectomy use has been increasing over time but remains low. Its use is associated with age, province, and provider volume. Patients with diabetes and or hypertension are treated with partial nephrectomy at the same rate as those without. Complications and in-hospital mortality related to age, comorbidities, and volume. So I'm going to move on to prostate to close out, and then hopefully we can have a discussion. And this was the most contentious of the health services projects we took on. We did in Ontario under the auspices of Cancer Care Ontario, and Joe Chin and Neil Fleschner were the leads on this initiative with Robin McLeod, John Irish, John Strigley from Pathology, and Andy Evans. And what we wanted to do was just assess the landscape of prostate cancer surgery in Ontario. So we started with a brief inventory to appreciate who's actually doing the surgery. And I'm not sure what it's like in BC, but prostate cancer is quite common, and there's no way certain centers can do all the cases, so everybody's doing them. And the vast majority are performed by non-uro-oncology urologists, 2/3 in Ontario. And the majority are in community hospitals. So we looked at a prostate margin audit, and we performed this as part of a pathology completeness project. So I'm not going to show you all the data, but we also had some CUOG funding for pathology here. And we developed standardized reporting and other templates to try to improve the overall care and quality for prostate cancer surgery. The pathology report audit assessed radical prostatectomy specimens, and we looked at 05 and 06 and overall positive margin rates. So the yellow is the overall positive margin, the lavender is a PT2, and PT3 is the burgundy. So our PT2 positive margin rate was about 30%. PT3 was nearly 60%. More than half to 2/3 of people undergoing surgery who had extra prostatic extension had a positive margin. I blanked out the LINs down here for confidentiality, but you could see the variance by jurisdiction within Ontario. We break ourselves down into areas called local health integration networks, and they're made up of a few hospitals, and that's what each of these sections demonstrates. Some of these are academic, some aren't, but you can see the variability is quite significant. So the KT strategy we developed here was meetings and something called the regional champion. And we had regional champions for both surgery and pathology. And our task was to go out and have little evening events with urologists and pathologists from the different LINs, and to review the numbers, review some of the pros and cons of how to perform a radical prostatectomy, ask them how they do it, and the pathologists discuss processing, a non-FOSS approach to the apex versus a standard approach. How do you process the gland so that things would be standardized across the province, and basically an effort to try to reduce positive margins in Ontario from a morbidity and cost perspective. And what we did then, we also had a scorecard, and some of this is going to become public and posted on websites, but we started with scorecards delivered to hospitals only. And what we found is that the rates dropped dramatically. PT2 is now down to 22%, PT3 is down to 30%. The homogeneity across the LINs is tighter, less variance. And for us, it's not to boast, but I think if you're going to take a leadership role in this and you want to be respected, you have to be twice as critical of the work you perform if you're going to go out there and ask others to look at their own work. When we first presented this, everyone thought it was a witch hunt. And then I think they began to realize that no one was trying to regionalize prostate cancer care. There's no way that one center can perform all of this. What we're trying to do is bring quality out in that form of surgery, and with the lower volume, higher acuity cases, bring quality in to one or two centers. And this worked quite nicely. Many urologists called me 1 or 2 weeks later and said they pulled their radical prostatectomy charts and actually looked at their own margin rates. And they thought it was quite valuable to go back and look at their cases because they really didn't have a sense of how they were doing. There was a lot of discussion between pathologists, and basically what we're doing here is trying to put health services into action, is developing now a better way of approaching the efferent arm. And surgery has really failed. We're working on a review article right now, and when you look at knowledge transfer, the vast majority of the initiatives are in medicine. And it's easier in medicine. New England Journal publishes a randomized controlled trial that an ACE inhibitor demonstrates this benefit. Most internists can pick up that manuscript and within months begin prescribing an ACE inhibitor that they're familiar with. If we publish a surgical paper that demonstrates a certain outcome or an advantage, not every surgeon is in a position to turn their practice around and do this. It's quite different. There's a technical component to it. So we tend to lag in uptake, but we also lag in effort, and I'm saying that amongst surgeons. So with every quality improvement process, what you're trying to do is identify problems, develop guidelines, standards, or some way of assessing what you think is appropriate, and then initiate the strategy and evaluate the results. And this has basically been done in Ontario for thoracics, for Whipple, hepatobiliary, for colorectal with mesorectal excision. Andy Smith's done a great deal of this work, and I would say across Ontario, our colorectal standards have improved greatly. And we're trying to do this in GU. So we spent the last 5 years, I've spent the last 5 years trying to acquire all the data that sets the stage for GU oncology surgery in Ontario. And now we've begun to roll out strategies to see if we can raise the bar across the board. And although this might not represent a great scientific discovery that results in a new therapy, at a grassroots level we may be able to improve the care for many individuals with what we have available today. And I'd like to close out on that note and acknowledge my collaborators, Shabir, Dave Urbach, George Tomlinson, our former fellow, Rob Abowassaly, who did his master's with us, Stan, who's doing his master's with us right now, excellent guys, my partners who've been very supportive of my research, and the agencies who supported me over the last few years. Thank you.